Bueno, buenas tardes. En primer lugar, bienvenidos a esta sesión, que en mi humilde opinión es la más importante del Congreso. Porque en el Congreso habrá mucha ciencia, pero en esta sesión va a haber pues, mucho cariño y mucho reconocimiento a la labor de unos compañeros, de unos cirujanos que han dado parte de su vida en diferentes proporciones, pero muy cerca del 100% de su empeño en curar y tratar pacientes con obesidad severa. Y en nuestra sociedad, la SECO tiene el privilegio y el honor de hacerles un reconocimiento como socios de honor esta tarde, ¿no? Obviamente, yo simplemente voy a presidir la mesa porque el protagonismo lo tienen no solamente ellos, sino los presentadores que van a hacer una especie de loa o resumen o lo que quieran ellos, ¿no?, de estos compañeros tan queridos por todos nosotros. Así que, sin más dilación, vamos a empezar la sesión y le doy la palabra al doctor don Amador García de Botejura, todos ustedes lo conocéis, y él va a ser el introductor y el que nos explique las razones por qué el doctor Juan Pujol Rafol es nombrado hoy socio de honor. Amador, cuando quieras.
Bueno, pues buenas tardes, gracias. La verdad es que costó muy poquito decidir el ofrecimiento de nombrar a Joan Pujol como miembro de honor de la SECO. Joan Pujol ya de joven apuntaba a carreras de altos vuelos, con su trayectoria se ha visto. Es la tercera generación de cirujanos de una familia de grandes cirujanos de prestigio en Barcelona. Estudió medicina en la Universidad Autónoma. Al acabar la carrera hizo un año de Surgical Fellowship en el Reino Unido y después se formó como cirujano en el Hospital Universitario de Bellvitge. Dentro del mundo de la cirugía bariátrica es uno de los socios fundadores de la SECO. Cabe destacar la organización del Congreso Ipso European Chapter de Barcelona en el año 2012, así como el Congreso de la SECO de ese mismo año. Ha sido miembro de la Junta de la SECO en diferentes ocasiones y ha sido hasta hace muy poco Chief de Ipso European Chapter Communication and Development Committee. Todas las actividades que ha realizado, no solamente a nivel nacional como europeo, pues le sirvieron el premio para ganar el Ipso Award en el año 2013. Pero Joan Pujol no solamente es una persona que se ha involucrado en el mundo de la cirugía bariátrica, es una persona que tiene también tiempo para el ocio, le gusta disfrutar de una buena comida, de una buena bebida, le gusta hacer deporte, el esquí, la bicicleta de montaña, le gusta viajar, le gusta la equitación y además me he enterado ahora que también le gusta el boxeo, con lo cual espero que después de esta presentación no quiera usarme a mí como punching ball. Pero sobre todo es un buen amigo, un buen compañero, una persona que ha colaborado en todas las actividades que le hemos solicitado desde la SECO, una persona especialmente importante a la hora de conseguir que este European Chapter se desarrolle aquí en Málaga. Y simplemente para agradecerle, pues hemos montado un pequeño vídeo que pueda servir un poquito de...
Cançoneta i món anem, que tot anirà bé, encara que el món caiga cantarem una última cançó que ho deixi enrere tot, que siga la penúltima, que l'última en favor. La penúltima vegada que vaig dir mai més serà un brindis a la lluna o era el sol, no ho tornaré a fer, no me senta bé. La penúltima liada forta no fa tant de temps i poco a poco vaig controlant els meus impulsos i el meu coco. Vaig a posar-vos la millor cara en les fotos, canviar el foco. És la penúltima vegada que el meu cap em talla el rotllo. Lo meu és massa fort, serà la mala sort, o sóc jo el meu problema. Però tu que em mires amb bons ulls, que saps tot el que vull, sempre tens la manera. Una cançoneta i món anem, que tot anirà bé, encara que el món caiga cantarem una última cançó que ho deixi enrere tot, que siga la penúltima, que l'última en favor. canzonetta in monade, una canzonetta in monade. Romeo es más amor, será la mala suerte, no soy yo me pone. Pero tú que eres un monstruo, que exhausto del tiempo, siempre des la manera. Una canzonetta in monade, que tonta mira ver, encara que el boca iba a cantar una última canción, que os deis el reggaetón, que siga la penúltima, que l'última es pavón.
Bueno, en nombre de la Junta Directiva de la SECO, para mí es un gran placer, un gran honor ofrecer el socio de honor al doctor Joan Pujol Ràfols.
Vale, sí. Bueno, no, es que me gusta moverme, sobre todo cuando estoy nervioso. Y lo estoy. A mí el micrófono me pone, pero es que, y mira que he dado charlas, pero como esta ninguna, ¿eh? Qué mal, qué mal. Recuerdo en el año 97 que Aniceto vino a Barcelona. Era amigo de mi padre, nos fuimos a cenar juntos, me comentaba, no eran 96, me comentaba, el año que viene vamos a hacer un congreso porque vamos a hacer una nueva sociedad de cirugía bariátrica. Yo llevaba entonces 50 casos de banda gástrica, que entonces era como una revolución. Ven, no sé qué, tal, tienes que venir. Y yo, no sé, ostras, bueno, qué vergüenza, pero vale, va. Y ahí empezó mi camino. Entonces conocí a la SECO y la SECO me lo ha dado todo. O sea, yo no entiendo mi carrera, sobre todo en el ámbito que me muevo, que es cirugía privada, sin esta línea docente, académica, profesional, que aparte de los años que he pasado en Belviche, pues por ahí he ido creciendo y desde luego no entiendo una cosa sin la otra. Y yo pensaba, pues vamos a comenzar a agradecer a gente porque son muchos, pero precisamente porque son muchos no lo voy a hacer, porque es que seguro que me dejo algunos, es que son prácticamente todos. Es la SECO que me ha dado a mí un montón de alegrías, al revés, yo no he dado nada, al revés, me la ha dado ella, o sea que solo tengo que agradeceros. Y como dice Manu, somos una familia, yo creo que es una de las sociedades más bonitas que hay. Sí que es verdad que cuando yo estaba a nivel de la Sociedad Internacional, estaba representando a SECO, estaba gracias a SECO y desde luego lo luché por la SECO porque me identifico con ella. Conseguimos el Congreso Europeo en el 2012, antes ya veníamos de Salamanca el Mundial, luego tuvimos el Mundial en Madrid otra vez, ahora tenemos felicidades Luis, espectacular. Además, creo que hemos roto todos los récords de inscripciones y yo estaba seguro de que iba a ser así. Y hemos de ir a por el Mundial, hemos de ir a por otro Mundial. Así que, y además lo haremos como siempre, todos juntos. Y además lo vamos a disfrutar todos juntos, porque es lo que toca. Pues nada más, muchísimas gracias y para siempre.
Enhorabuena, Juan. Vamos a pasar a la siguiente socia de honor, que es Isabel Otero Martínez, y para ello nada más y mejor que la doctora Raquel Sánchez Santos para loar su carrera y los méritos adquiridos por Isabel. Adelante, Raquel.
Bueno, es un honor para mí presentar este nombramiento. Yo no traigo vídeo ni musiquita tan animada, que a ella le hubiera gustado porque le gusta mucho bailar, pero la verdad no sabía que era la vibra que dicen ahora. Podía haberlo traído, traigo unas diapositivas así de estas normales de toda la vida, pero bueno, voy a aprovecharlas para contaros un poco pues, algunas cosas de Isabel. Muchos ya la conocéis. Yo trabajo con ella desde hace 8 años en el Hospital Álvaro Cunqueiro de Vigo y la verdad que bueno, pues, ha sido un honor trabajar con ella y bueno, pasar muchos buenos ratos juntos también en esos congresos de SECO, ¿no? Os cuento un poquito sobre ella. Se licenció en la Universidad de Santiago de Compostela, luego hizo la especialidad en el Hospital Seralcíes de Vigo y una tesis doctoral también relacionada con el cáncer. Hizo una rotación cáncer gástrico, hizo una rotación en el National Cancer Center de Tokio y quería destacar un poco sus cualidades como líder y también en cuanto a formación de comunidad. Ella pues, tuvo el honor de ser la primera presidenta mujer, me refiero, de la Sociedad de Cirugía de Galicia, que fue un hito y además una pelea de alguna forma para romper moldes, ¿no? Yo creo que ella a lo largo de la historia ha roto varios moldes, también siendo jefa de sección de cirugía esofagástrica y bariátrica del complejo hospitalario de Vigo, pues muy pronto, hace muchos años, en un momento en el que había pocas mujeres con este tipo de responsabilidades, ¿no? Ella fue líder en el desarrollo de la cirugía laparoscópica avanzada del Hospital Mesoiro de Vigo y siempre ha tenido un gran espíritu colaborativo, ¿no? Ha estado rodeada de un buen equipo, me incluyo en el equipo también, y bueno, siempre ha sido pues, la coordinadora tanto del Comité de Obesidad como de la sección de esofagogástrica. Además, tiene una gran vocación docente porque fue tutora de residentes muchos años, colaboradora docente y hay muchas generaciones de cirujanos de Vigo que han aprendido mucho de ella, ¿no? Y que de alguna manera pues, han dependido mucho de ella cuando había casos complicados y siempre pues, vamos a llamar a Isabel a ver qué nos dice, ¿no? Ha sido directora y profesora de múltiples cursos de cirugía laparoscópica y bariátrica, tanto de la EC como de la SECO, dirigidos a residentes y a especialistas, y destacaría también un gran compromiso con la SECO. Empezó la cirugía bariátrica con el doctor Casal y el doctor Maruri por los años 2000, me vas a perdonar, pero es que el año justo pues no lo sabía. Sí que sé que fue socia de la SECO desde el 2007 y desde entonces, no sé si posiblemente no falta ninguno de los congresos de SECO. O sea, ha venido a todos los congresos de SECO, siempre aportando comunicaciones, vídeos, siempre aportando la experiencia y compartiendo un poco con la familia de SECO que decía Joan Pujol, ¿no? También a muchos de los congresos de IFSO, tanto los mundiales como los europeos, aprovechando pues, la parte científica, pero también disfrutando un poquito de la parte social, ¿no? Disfrutando de esos sitios maravillosos como Málaga, donde se hacen estos congresos, ¿no? Y en los que algún ratito también se puede disfrutar. Y bueno, pues para mí es un honor estar aquí presentando este nombramiento y te doy mi más sincera enhorabuena. Así que Isabel, si te puedes acercar.
Por miedo a ponerme nerviosa, me escribí unas notitas. Muchas gracias por ser nombrada socia de honor de SECO. Es un gran logro muy significativo para mí. Yo solo he sido una curranta dentro del mundo de la cirugía bariátrica. A lo mejor tengo menos facilidad para dar charlas o ponencias, pero en el trabajo del día a día creo que nunca se me ha hecho de menos. He trabajado todo lo que he podido. Entonces, tengo que agradecer a Raquel, porque seguramente este nombramiento promovido por ella nace del afecto personal. Es un gran honor, probablemente mayor del que merezco, recibir esta distinción. Como ella dijo, pertenezco a la sociedad desde sus inicios. Ya en el año 97, Enrique Casal, que era el jefe de servicio del Meixoeiro, y a pesar de que él se dedicaba al mundo de la coloproctología, tuvo un interés en especial en que se desarrollara el tema de la cirugía bariátrica. En aquel momento solo Ignacio Maruri y yo éramos los encargados de esta cirugía, y cualquier paciente obeso que llegaba al servicio parece que ya tenía que ser solo atendido por nosotros, tuviera lo que tuviera. Tuvimos que trabajar mucho con la dirección médica, con los gerentes, para intentar fomentar este área de la cirugía y llegar a crear un área multidisciplinar, que era lo que nos interesaba. Esto, con el tiempo, ya en el Hospital Álvaro Cunqueiro, pasamos de ser 2 cirujanos a ser 6 cirujanos dentro de la unidad, y cirujanos comprometidos, colaboradores y altamente cualificados, y además, bajo el liderazgo de Raquel, pues la situación cambió significativamente. Hoy puedo decir que me enorgullezco de haber formado parte de una de las unidades líderes a nivel nacional de cirugía bariátrica. En cuanto a la SECO, para mí me gusta su espíritu por ser una sociedad cercana, donde sus socios se conocen, se ayudan y donde existe un fuerte compromiso en la formación de los nuevos cirujanos, con cursos, con becas. Es decir, es algo que me parece muy interesante. Yo me he jubilado recientemente de la sanidad pública, sigo peleando en la medicina privada. Y creo que a estas alturas probablemente no tenga nada que demostrar, pero mi entusiasmo por el quirófano y mi deseo de seguir aprendiendo permanecen inalterables. Este reconocimiento refleja el duro trabajo con otros colegas en el pasado, en el presente y espero que en el futuro, que han sido parte de mi vida profesional y son de hecho incluso familia. Mi hija sigue en el hueco que Raquel consiguió para ella, con un perfil de cirugía esofagogástrica y bariátrica. Nada más. La cirugía bariátrica me ha aportado mucho más de lo que imaginé, tanto en lo profesional como personalmente, y por lo que estoy muy agradecida. Quiero agradecer a SECO este honor y por seguir alentando la conexión y el aprendizaje. Y gracias, Raquel, por tu liderazgo, generosidad y amistad. Recibo esta distinción con mucho agradecimiento.
Enhorabuena otra vez, Isabel. Bueno, y ahora, no sé, la mayor parte de vosotros sabéis que yo soy de Málaga, ¿no? De un pueblecito de Málaga que se llama Coín. Y para mí ahora es un momento muy importante. Es el reconocimiento como socio de honor de un cirujano al que quiero muchísimo y que se llama Enrique Gluzman Maldonado, y va a hacer la presentación otro grandísimo amigo mío, que es el presidente además del Congreso, al cual le felicito por lo hasta ahora conseguido y lo que está por conseguir, el doctor Luis Ocaña. Cuando quiera, Luis.
Bueno, buenas tardes. Como podéis imaginaros, la emoción que tengo coincide con lo que al principio dijo el doctor Torres. Pues no sé si tengo 10 o 12 intervenciones en este congreso, lo cual me corresponde como presidente, pero evidentemente para mí esta es la sesión más importante para mí de este congreso. Y he tenido la inmensa fortuna de poder, en el congreso que organizo, pues tener el honor de presentar a mi amigo y compañero y maestro, Enrique Gluzman. Bueno, esta foto me ha costado encontrarla. tiene casi 30 años. Y es que hace casi 30 años y celebrando pues casi el primer aniversario de la muerte de nuestro maestro, el doctor Manuel Domínguez García, pues ya celebramos una reunión de obesidad en el hospital. Bueno, pues ahí reconocería a muchos compañeros, veréis que en alguna de las fotos va a salir obviamente el doctor don José Rivas Marín, porque realmente es inseparable la cirugía bariátrica en nuestro hospital sin contar con él. Pues ya en aquel momento estuvimos bueno, pues empezando a hablar de una cirugía o empezando a plantear una cirugía que es verdad que en aquella época pues era cirugía pues muy poco usuales en los hospitales, nada que ver obviamente con lo de hoy día. El ser una persona inquieta, el ser una persona moderna, no tiene absolutamente nada que ver con la edad que se tenga. El doctor Gluckman, después de hacer la carrera en Málaga y empezar en el Hospital Civil la especialidad de cirugía general y del aparato digestivo y después seguir toda su vida profesional en el Hospital Clínico Universitario Virgen de la Victoria de Málaga hasta el año 2017, donde, según él nos dijo, no se jubila, sino que se retiraba de la sanidad pública, pero para seguir trabajando y mucho más, y doy fe de ello, de lo que se hacía hasta ese momento. Pues, como decía, el ser una persona moderna, el ser una persona inquieta, no tiene nada que ver con la edad. El doctor Gluckman, y yo he sido el gran beneficiado porque siempre que iniciaba un viaje para aprender alguna técnica en cualquier parte del mundo, en la maleta iba el doctor Ocaña, pues se fue a Seúl a formarse en radiofrecuencias nódulos tiroideos, se fue con Kelvin Higa a Fresno, California, para formarse en cirugía bariátrica, se fue también a Bangkok, a Tailandia, para aprender abordajes remotos para la cirugía endocrina. Y yo, que llevo con él trabajando 30 años a solo 30 centímetros, que es la distancia que hay entre dos cirujanos que están haciendo una cirugía endocrina, os puedo dar fe que no hay día en que no esté intentando convencerme para ir a algún sitio, para ir a aprender algo nuevo. Así es su inquietud y, como os digo, bueno, pues aquí están el doctor Gluckman y el doctor Rivas con nuestro querido y añorado Nicolás Copinaro, que, como sabéis, pues ha sido un referente para todos nosotros. Y bueno, pues empezamos a ir a todas las reuniones de SECO, como no puede ser de otra manera, desde la famosa reunión de Salamanca, que aquí ya se ha comentado, donde fue el Mundial, hasta aquel momento en que a todos se nos heló la sangre en Getafe cuando vimos a Kelvin Higa hacer un bypass de 25 minutos, como nunca lo habíamos visto hacer, ¿no? Realmente esa es nuestra historia, es la historia que hemos tenido todos somos partícipes de esa historia y, por supuesto, el doctor Gluckman está en ella desde el principio. De hecho, es uno de los primeros acreditados como experto en la Sociedad Española de Cirugía de la Obesidad. Y bueno, también pues empezamos a movernos por otros sitios. Ahí estamos con Henry Buchwald, estamos también con Michel Garnier, por supuesto, atendiendo todos los congresos. Empezamos yendo en el año 2008 a Argentina y movíamos nuestras vacaciones de verano, todo el grupo, el doctor Rivas, el doctor Gluckman, nuestras esposas, por supuesto, para ver y, por supuesto, fuimos a la India, fuimos también a Montreal, etcétera. Era como una especie de destino deseado cada verano, ir al congreso, aprender mucho y también estar juntos y compartir, en fin, estar dentro de esa gran familia que es IPSO. Y siempre con trabajos, con publicaciones, con compartir nuestras experiencias, nuestros sufrimientos, porque el cirujano bariátrico sufre mucho en quirófano y qué mejor que hacerlo en estos congresos donde todo el mundo siempre nos aporta algo novedoso, como espero que sea obviamente en este congreso de Málaga. Pero al mismo tiempo también hemos tenido tiempo de compartir y aquí estamos con nuestro querido Antonio, como sabéis ya se ha presentado él también como malagueño. Para nosotros encontrarnos en cualquier parte del mundo con él o en España pues es un auténtico placer. Bueno, hasta aquí es lo que el doctor Gluckman llama lo que es su hobby, porque él dice que realmente su trabajo lo representa esta diapositiva. Os puedo decir que él se ha dedicado en cuerpo y alma a todo lo que ha hecho en su vida. Y las carreras ha sido algo a lo que le ha dedicado también cuerpo y alma. Pero en esta definición yo no estoy tan de acuerdo, porque un cirujano tan honesto, que siempre ha hecho las cosas igual de bien, que nunca ha escatimado lo mejor para cada paciente, ni en el periodo diagnóstico, ni en el quirúrgico, ni en el posoperatorio, puede decir que su hobby es la cirugía. Quizá esos dos son sus dos trabajos y eso es lo que yo le quiero decir hoy a Enrique, que nunca se lo he dicho. Él siempre ha sido una persona también que ha competido muy bien en los foros científicos en el que ha sido siempre invitado y siempre con honestidad, siempre con mucha educación, pero siempre con el conocimiento que le da tantos años de experiencia y tanto que ha transmitido. pero donde realmente el doctor Gluckman está en su salsa es con su familia. Y digo con su familia porque todos los que estamos aquí somos familia. Enhorabuena, Enrique.
Bueno, la verdad que estoy un poco abrumado por la presentación tan cariñosa que Luis ha hecho de mí. Él sabe perfectamente que el cariño que acaba de demostrarme es un cariño mutuo que tenemos. Y os voy a decir una cosa, como ha dicho antes el doctor, mi compañero, Joan Pujol, yo estoy acostumbrado también a dar bastantes charlas, pero debo de reconocer que en ninguna he estado tan nervioso como estoy hoy. Solamente voy a dar unas breves palabras para mostrar mi agradecimiento a la SECO, a la Junta Directiva de la SECO, a la doctora Raquel Sánchez, que siempre ha sido alma de ella, a la doctora Fátima Sabenys, Antonio Torres, que ha sido un referente en el mundo, presidente de la ISO, presidente de la SECO. No hay un perejil en la cirugía bariátrica donde él no esté, al doctor Amador García Barrijuela y, sobre todo, a mi compañero, amigo y casi, como él ha dicho, familia Luis Ocaña. Siempre suelo decir lo siguiente, y es que lo llevo en el corazón. Cualquier mención significa siempre una nueva fuente de estímulos. Os digo de verdad que desde que terminé la carrera jamás en mi vida me he levantado ni un solo día sin el interés de aprender algo nuevo. De todas formas, debo de agradecer de una forma muy especial a la SECO este nombramiento en la ciudad de Málaga, en mi ciudad, donde he nacido, donde he trabajado, donde he desarrollado mi carrera. Es cierto que he estado en muchos sitios en el extranjero con la intención de aprender siempre algo para luego podérselo ofrecer a mis pacientes y hacerle el mejor bien posible. Y me tengo que rememorar a 1994. En el año 94, cuando iniciamos el programa de cirugía bariátrica en nuestro hospital, en el Hospital Virgen de la Victoria, con mi compañero, el doctor José Rivas, del que he aprendido lo que no se pueden ustedes imaginar, la cantidad de cosas que me ha enseñado, porque es un hombre que todo lo que sabe trata de traspasárselo a los demás. Pues en aquel entonces mucha gente en el hospital nos tachó que éramos un puñado de locos. Nos metíamos en terrenos donde iba a haber unos grandes problemas, pero bueno, animados por don Aniceto Baltasar, pues lo fuimos sobrepasando. A día de hoy, 32 años después, debo decir que ha valido la pena. Y lo único que les debo decir a la SECO, que por favor trate de transmitirle a toda la gente joven que hay en la SECO que tengan interés porque nuestra sociedad siga desarrollándose, siga siendo el referente que es a nivel mundial. Muchísimas gracias.
Muchas gracias, Enrique, y enhorabuena. Bueno, ahora vamos a hacer un impasse. Habíamos pensado que los premios y las becas que se van a dar, que va a la SECO, más después de que termine su exposición el profesor Patou. And now I'm going to change to speak in English. François, where are you? Okay, over there. So for me also it's a great pleasure to presented, Professor François Patou from France in terms of becoming a new honorary member of our society. For us, it's a great honor. And for, doing or speaking some words, saying some words about him, here we are, Fátima Sabenys. She's going to say a couple of words about this outstanding professor of surgery there. So, Fátima.
Gracias. A ver. ¿Se ve? Perfecto. Bien, muchísimas gracias. Voy a hacer una presentación un poco diferente de lo que se ha estado presentando. François Patou es una personalidad conocida por toda la comunidad científica. Yo creo que no necesita presentación. Él es cirujano, profesor de cirugía de la Facultad de Medicina de Lille y es jefe del Departamento de Cirugía General y Endocrina del Hospital Universitario de Lille. También dirige un potente grupo de investigación dentro del Instituto Nacional de Salud y de la Investigación Médica, INSERM, centrado en el desarrollo clínico de bioterapias para el tratamiento de la diabetes. Además, es también miembro fundador del European Genomic Institute of Diabetes y ha sido beneficiario de numerosas ayudas de investigación, tanto nacionales como internacionales. Ha recibido también numerosos premios y distinciones a lo largo de su carrera académica y profesional. Esta sería, bueno, la definición convencional, ¿no? Lo que uno puede encontrar cuando busca a François Patou o cuando pregunta por François Patou, ¿no? Esto es una cosa pública, pero yo creo que François Patou, para quien lo conoce, sabe que no es una persona convencional. No, dice que no. François Patou es ante todo el ejemplo de una figura que ha sabido moverse con naturalidad entre el quirófano, el laboratorio y áreas como la endocrinología o la salud pública. Desde sus primeros trabajos en Lille, su trayectoria sobresale a la tradición de la medicina académica francesa, con una práctica clínica exigente, profundamente anclada en su caso a la cirugía endocrina y que muy pronto se abrirá a la investigación translacional y a la medicina personalizada. En sus inicios, su atención se centró en el páncreas endocrino. Sus trabajos sobre trasplante de islotes pancreáticos y la fisiología de las células beta reflejan ya una voluntad clara de intervenir en la raíz del problema, no solo en sus consecuencias. Con el paso de los años, su campo de acción se amplía de forma natural hacia la cirugía metabólica. La obesidad y la diabetes tipo 2 pasan a ocupar un lugar central en su investigación. Aquí su enfoque adquiere una dimensión particularmente vanguardista. No trata únicamente de operar, sino de entender por qué la cirugía funciona, en qué pacientes lo hace mejor y cómo podemos anticiparnos a sus resultados. Sus publicaciones aquí muestran un carácter predictivo, con seguimientos a largo plazo y aunando en la personalización de los tratamientos. En su etapa más reciente, su trabajo da un paso más hacia la integración de disciplinas. Participa en estudios poblacionales, incorpora herramientas de modelización avanzada y colabora en proyectos donde convergen clínicos, biólogos, epidemiólogos y expertos en datos. Esta evolución no es casual, porque refleja una comprensión cada vez más profunda de la complejidad de las enfermedades metabólicas, las cuales no pueden abordarse desde un solo único prisma. A través de esta trayectoria se dibuja una personalidad científica sorprendente. Es un investigador pragmático, interesado en soluciones concretas y tremendamente curioso. Sus colaboraciones amplias y multidisciplinares apuntan hacia un modelo de liderazgo transformacional, huyendo del modelo clásico o piramidal. Patou quiere romper las fronteras rígidas entre especialidades y modelos. La figura de François Patou puede entenderse mejor si conocemos las obras de su padre, Jean Patou, tal y como me han comentado compañeros suyos. Un conocido arquitecto francés y pintor, el cual no se limita a organizar el espacio, sino que además lo interpreta. De ese entorno intelectual y creativo se forma François. De Jean Patou se transmite una manera de pensar abierta, moderna y capaz de integrar rigor y creatividad. En François, esa herencia se manifiesta en la innovación médica, en la voluntad de explorar nuevas soluciones y en una práctica que no se reduce al paciente a un caso clínico, sino que lo entiende como un sistema complejo, casi como un paisaje a ojos de su padre. Su recorrido transmite la imagen de un clínico que ha sabido evolucionar hacia un papel amplificador, alguien que parte de la precisión quirúrgica para acabar pensando en términos de sistemas y poblaciones. Es, en definitiva, el retrato de un médico científico expansionista, pero manteniendo el objetivo claro de mejorar de manera tangible la vida de los pacientes. Sus más de 500 artículos científicos y más de 30.000 citaciones así lo avalan. Tengo que decir que personalmente tengo una debilidad y, por qué no negarlo, una envidia y no sana por sus estudios de la MASLD o por los trabajos sobre el estudio de modelos predictivos acerca de la respuesta a la cirugía de la obesidad. Y ahora vais a perdonar mi francés, pero me atrevo a decirle unas palabras en francés. Pour toutes ces raisons et en reconnaissance de votre carrière exceptionnelle, de votre engagement et de vos contributions scientifiques inestimables, votre nomination en tant que membre honoraire de la SECO a été proposée et approuvée à l'unanimité. Cette distinction reflète non seulement notre gratitude, mais aussi le profond respect et l'admiration que nous portons à votre travail. Merci d'être une source d'inspiration pour notre société. François, merci beaucoup d'avoir accepté cette nomination.
Congratulations.
And now, Professor Patou is going to give us a lecture, entitled The Bariatric Surgeon and the Liver, a Love Story. François, your turn.
Thank you very much, Antonio. But first, so I will be speaking in English. Sorry for that. I'm not fluent in Spanish, even though I was born in Saint Juan de Luz, not very far from your border. But so I will speak in English. But first of all, I would like to thank you with my deep heart. It's an immense honor for me, and around me it's my team and also the French Society. So we really thank you very much for this very important honor. So again, thank you so much for having proposed me for this honor. So this is the story I was asked to tell you. So I was given a lot of time. So I'm afraid you're not going to be bored, but I will try to summarize nearly 30 years of research in one topic, which was the steatotic liver, which was not the only topic, but was an important topic for our team. So this is our hospital. This is the West Wing. So if you go there, this is the stair. So I'm living in Lille. It's a town in northern France. And I will tell you about a story that has taken me 30 years. So I started bariatric surgery with my previous mentor, Charles Proy, exactly 30 years ago. And so I have some disclosure, but my main disclosure is, of course, enthusiasm for this incredible field of bariatric surgery and trying to expand it for a long time. This little drawing, I just put it because it was very special for me. I was very beginning the career, and one of the patient's general practitioner sent me a patient with a letter with this drawing. You can see here, and I understood with the very first consultation that this is always an ambivalent world, and it's very difficult for us to convince others that we are in the right direction. But you've been fighting with us for decades too. So, of course, this team, this liver work has been done by a team. So around us, there is a lot of people, of course, in the surgical department. You know, I'm sure, Robert Cayazzo will be there today and the next days, but also other surgeons and clinical researchers that are working with us in the surgical department. But also for the liver, we need colleagues, and we need the colleagues from the hepatology department. And I've been fortunate enough. I'm putting the team player in the beginning because we always forget that at the end, and this is so important. We'd like just to insist on a few names. Philippe Mathurin is my counterpart. He's a hepatology professor with Guillaume Lassailly, a younger one. He's Robert Cayazzo. And together, we've been doing that for decades together. It would have been never possible without him. Of course, pathologists, a biostatistician, and of course, researchers also are involved. Okay, so I chose this plan. So once upon a time, a story. I'm going to tell you a story of 30 years of research in Lille. So as you will know, it started with blind date, as many stories, good stories. It was a bit surprising in the beginning. And then I will go through our journey in these difficult patients and their treatment by metabolic surgery. So this is the blind date. So liver failure after bariatric surgery. And I have to say that when I saw this paper coming from Spain, it was exactly 25 years ago, it rang a bell, because I saw the same patient in Lille 2 years before. So patients having been operated with scopio-narrow operation, and after years after surgery, because of protein denutrition, all of a sudden, severe denutrition and liver failure at risk of death. And this was a case of liver transplantation after biliopancreatic diversion, scopio-narrow operation, performed in Spain. First case reported worldwide in the literature. So this was very important for me. And that explains me why, when I accepted to embark into this surgery with my boss, Charles Proy, I was much younger, of course, 35 years old, and even less, I have to say. And so really, I was really worrying about this liver story. So that will explain a little bit a part of the story I'm going to tell you, which is by some aspects pretty strange, because we did a lot of things that have been never done anywhere else and will be never done again by anyone else, I think. So let's try that we wanted to know each other a little bit better, and that was the beginning of the story. So a little bit of introduction with this fatty liver disease, now called, as you know, not anymore non-alcoholic fatty liver disease, but this is the name, metabolic associated steatotic liver disease. So this is a strange disease. It's an important disease, but it's a strange disease because the diagnosis first requires a liver biopsy. Very few diseases requires such an invasive diagnosis diagnostic test. Second, the pathogenesis going from normal liver to steatosis, to inflammation, and to cirrhosis and fibrosis is not very well understood. It is described, but not very well understood. Then the disease progression, will come back on that, is very heterogeneous. Many trajectories are possible. And of course, treatment response is limited. Drugs are just pumping up for the last 2 years, but it's very recent, and their answer is very unpredictable. So that's the disease we are talking about. And I think that's the next metabolic frontier for the field, but also for bariatric surgery, a very important one. On the left, you have the epidemiology. And this colorful map, world map, rings a bell. It is about diabetes, obesity. Any of these metabolic diseases will follow the same pattern. This is the prevalence of the MASLD disease in the world. So you can see that, of course, our countries in Europe are a little bit red, but we are not the worst. Of course, North America with Mexico, Middle East, and burgeoning countries such as India is a very important provider of this disease, are all around the world. Importantly, on the right, you have in a recent review of this pathophysiology, you have the natural history from the steatosis, simple steatosis, to inflammation, to cirrhosis, to hepatocarcinoma, and to liver decompensation. I would like just to stress that the disease we are taking care of is not the steatosis. This is like prediabetes or something which is a risk factor, but not a disease. What we are aiming to treat and to fix, that's what surgeon likes to do, to fix things, is the advanced liver disease, and that's why I will focus my talk on. Importantly also, this disease follows very various clinical trajectories with very various outcomes at the end of the road. On the left, you have all the potential trajectories going from the risk factor to the early disease, to the more advanced disease, and at the end, the different outcomes. Some of them are, of course, liver outcomes. Hepatocarcinosis, liver decompensation, hepatocarcinoma. But many other outcomes linked to the disease of the liver are cardiovascular. And on the right, you have a pretty surprising drawing which tells you that in these patients with severe advanced MASLD, the most frequent cause of death is cardiovascular. It's not liver. Mostly it's cardio-specific disease and also, of course, extrahepatic cancer. So, of course, the liver outcomes are very dramatic, but they're not the most frequent, even in these patients, given the association of the disease with obesity and dysmetabolism. So important to understand. So to understand better the disease, what I did 30 years ago with the team is embark into a very strange, at that time, and brave theoretical aim, which was to build a prospective bariatric cohort. But we've been doing that for 30 years. So now there is more than 3,000 patients that have accepted either to be followed or for some to be enrolled formally in an invasive study where you have tissue sampling, of course blood sampling, and a very deep phenotyping on the way of the follow-up. So that means that every patient in our university department is treated, but is also followed for research if they accept, of course. So this is the typical follow-up, which is following baseline at 1 year, 5 years, and then every 5 years we try to follow every patient. And you'll see we are not, of course, perfect, but we are quite good at it because of the French system, which is paid for, so both surgery and follow-up are reimbursed. So we've done a lot of things, and I will just go through very few little things. So back to the disease. MASLD, okay, we know, we have listened a little bit, but now what is MASLD in our patients? The one with class 2 and class 3 obesity. That was an important opportunity window to check because we had access to each patient to a liver biopsy. So the hepatologists do liver biopsy because it's an invasive test only in selected patients. So they have a window, selected window on the very specific aspect of the disease. We have access to all patients with class 2 and 3 obesity, which is a different, more reflecting the normal situation. And this is what we found. This is quite interesting. So you have here a typical biopsy, of course, during the surgery with a quite bad liver, as you can see. But interestingly, we found, of course, that MASLD, so the yellow and red point, are, of course, in the most patients present. So steatosis is present, but not, and that's a surprise, not in all patients. Even in our patients, mean BMI in our department is 48 kilograms per square meter, so quite heavy patients. Normal liver, totally normal liver, like the control patients with lean mass, total normal liver is seen in about 18% of patients. So you have patients with severe obesity, totally normal liver. On the other side of the spectrum, in red, you have the MASH patients. And in our hand, in this non-selected routine biopsy cohort, you have 12% of patients, so let's say nearly 10%, 1 out of 10 with MASH. So it's a little bit less than what is currently reported in the literature. Same thing for the very fibrotic liver. So MASH and advanced fibrosis will go together, each of them for 10%. So a few numbers that are quite interesting to share. So not all the patients with severe obesity have MASH, of course. Second thing is that the MASLD is very heterogeneous in terms of clinical and biological simple aspects. Here you have a complex three graph that I will go through. So comparing MASH in red and no MASH patients. And you can see that there is not a single parameter that can predict MASH. Age, of course, is associated with MASH. The older, the more risky. BMI the same, but you can see easily on this graph, but there is no rule. There is not the old and heavy patients will have MASH, whether the young ones will not have. It is not like that. Same thing for even liver enzyme and dysglycemia with HbA1c. Same thing for dyslipidemia. You can see, of course, a tendency, but there is not a single marker that can tell you this patient is at risk and this one is not. So recently, I will just go briefly with that, but I think that's quite interesting. Together with this cohort, beside the surgical story I will tell you, we had access to an incredible resource, which is these thousands of patients with a lot of data. And we've been able, with colleagues of mine in the team, to analyze cross-sectionally the full cohort of MASLD and with artificial intelligence, so we can do all the hundreds of variables that were here. And long story short, we were able to show for the first time that this disease is exactly like clinicians think. It is a single name, it looks the same in the liver, it's called MASLD and MASH, but beside that, beyond the liver histology, there is two different forms of disease. Different biological underground, genetic for one, and different outcomes, clinical outcomes. And what we've been able to describe is two subtypes of MASH. One in blue is liver-specific, the other one in red is cardiometabolic. And long story short, what we found is that very simple, just 6 simple variables are needed to classify these patients with this clustering. And they have the same liver outcome, but very different cardiovascular outcome. Long story short, the liver-specific disease, the liver is the cause of the disease. It's genetically driven, and there is no extra cardiovascular risk. For the other one, the cardiometabolic liver disease, the liver is the victim of the cardiometabolic surrounding. And in this case, patients are very high risk of cardiovascular disease. So this is just a story which is starting. The paper has been published 1 year ago, cited 150 times already, and 2 big studies in cohort in China and USA have reproduced the exact same pattern. So this is going to stand, and it's strange because most clinicians know that. Some patients will go to cardiovascular disease, others will stay with the liver disease. So just to tell you a little bit about the disease we start with. Now go back to the second part of the talk, which is MASH and metabolic surgery. I'm not saying metabolic surgery for MASH. I'm saying just let's try to not, because we know each other now, let's try to get along, to date together. That's what we did. We know that in this cohort, we have studied many things post-operatively. First of all, of course, is weight loss trajectory. So this is maybe a tool that you have tried yourself. So this is something we developed a few years ago now. It's called a SOFIA calculator. It can give individual prediction of the weight loss trajectories, calculated data-driven by artificial intelligence, again with very simple variables to start with a quite acute precision, very useful tool to engage a conversation before surgery with your patients. This tool has been used 1 million times worldwide and is used 1,500 times every day by clinicians worldwide, from South America to China. So this is quite interesting. The version 2 is coming next year with other input, but this is just the type of things we were able to do with this cohort of 3,000 patients. Now, coming back to the metabolic disorder, of course, we are able also to look at type 2 diabetes remission. This is a story we all know now, that surgery is associated with a very good rate of type 2 diabetes remission, a strange word for diabetologists that I was not taught when I was at school, at medical school, of course, but is now obviously that 50% of patients following surgery, bariatric surgery, of course, there is a gradient between operation, but we know that nearly half of the patients will experience diabetes remission at least for 5 years, which is quite a piece of life and significant outcome. So this is known, and we have just, of course, just confirmed that and put some little details on that story. But let's go back to the liver. So for the liver, what we did with this cohort is we proposed, and I was not crazy, I was just afraid because of the Spanish paper, because of my experience, clinical experience, that we are going to harm people with severe obesity by putting them at risk of liver disease by rapid and dramatic weight loss. This is why I proposed, honestly, to every patient enrolled to have not only a liver biopsy at time of surgery, which is easy, but also at 1 year and 5 years. And I had to work a lot and talk a lot for each of these patients when they came back to convince them to go down and have a liver biopsy at 1 year and 5 years. Not all of them accepted, but most. You can see that this is the clinical numbers, the clinical follow-up. So meaning that you see in France, because it's free, because they are welcome at the hospital. So we have nearly everyone at 1 year, and let's say 3 out of 4 patients are coming back at 5 years. Coming back, it's not by phone, it's blood sampling, it's deep phenotyping. And among those patients, in red, are those who at that time accepted to have another liver biopsy. So this is quite research effort, of course, but it's interesting. So at the end of the day, we had nearly 700 patients with longitudinal research routine biopsy, not because they were at risk of something, but just because they were enrolled in the study. So this is a totally unique thing, and because of the story I'm going to tell you, no one is going to do that again. So this will remain unique. We published that many times with my friend Philippe Mathurin, and of course I was backed with the pathologist who did the biopsy and were with us to that, because it was quite a strange effort and big effort altogether. Okay, so first of all, what we found, this was published, first paper is 2004, John Krall in New York, who described different biopsy at different time, saying that the liver is improving. But this was just cases. This was a case series. This is a longitudinal systematic study. And we showed, and we can go here, as you can see, go back to the pathologist and said, Mrs. X I would like to see the biopsy at 0, 1 year, and 5 years. And this is what we found. Severe MASH at baseline, at 1 year improvement, and at 5 years, total remission of the disease, normal liver. These things, when we first published that, it was at the European Surgical Association with a lot of liver surgeons, was a bit surprising. The field never saw that. The drugs did not exist. Weight loss was not enough. And that was exactly, but they believed us because they saw that with viral hepatitis years before. So if you cure the disease, the liver will improve. If you cure the inflammatory metabolic burden, the liver will recover. And you can see normal liver in the same patients, a lady of 60 years old with severe MASH at baseline. So then we can count and do numbers. And so that was the next papers in 15 and 20 by Guillaume Lassailly, a colleague I just already mentioned. So first of all, we were able to show that this NASH resolution was quite dramatic. At 1 year, it was seen in 85% of patients. So 100 patients with MASH, 85 with no MASH 1 year later. This is in blue, and you can see also there is a gradient with the weight loss. The more weight loss, the more efficient. And that makes sense, but it was even more dramatic than with weight loss. On the right side, you have the fibrosis component. And you can see here that it takes more time, which makes sense, because the cause is out, the liver stops to be destroyed, but the liver fibrosis needs time to recover. But at 5 years, it was not as perfect. It was not 80%, but it was, we'll come back to that, more than 2/3 of patients with fibrosis improvement. So it takes more time, but fibrosis also improved. So now, more recently, we focused on the patients with significant fibrosis. We know that fibrosis, F0, of course, is no fibrosis, but F1 is in between. F2 has been associated with mortality risk. So this is a disease which is severe, will kill people. And what we were able to show is that if you look at 5 years, among the patients with significant fibrosis more than F2 at baseline, 2/3, 64%, will go back down there at F1 or F0, 2/3 of them. And you can even see, of course, we operated very little patients with cirrhosis. It was a contraindication in France at that time, and only the patients with incidental cirrhosis at pathology are on the side, because the other ones were excluded at that time. But you can see that we've seen patients with cirrhosis disappearing. Cirrhosis, histologically proven, disappearing at 5 years. So that was quite impressive and in line with what I've just showed you for the inflammatory process. So now recently we have checked, because many studies, maybe not as large as this one, but other series of double biopsies or longitudinal biopsies have been published. Some are just retrospective analysis, some are within randomized trial. And especially we mixed on this figure that I will explain, surgery, but also any other weight loss intervention. And we have now nearly 10 drug intervention with the modern drugs, GLP-1 analogs, but other more specific drugs that have been approved or at least published in very big journal in the recent years. So on this graph, you have on the left the steatohepatitis resolution, on the right the significant fibrosis resolution, so two different outcomes. You can see on the color is the weight loss described by the paper for each of the study. And the size of the round is the number of patients involved. So you can see that all the round with a name are drugs. The other ones are surgical series. And you can see that all the round with a name are in the lower end, of course. This is drugs, so it is efficient, but it's not the same thing. And you have, of course, the resolution outcome on this graph. So you can see that there is a very nice weight loss gradient. The more weight loss, the better resolution you see. And you can see also that only surgery has provided data long-term. Our study, but also others, you can see 2 studies on this 5 years outcome have been shown there. And you can see again, very consistent. In surgery, around 80% of patients with resolution of MASH persisting from 1 year to 5 years. On the right, you have the consequence, which is significant fibrosis resolution. It takes more time. Not all the patients will go there, Maybe many patients more will go after years and years if the disease is not recurring. But you can see also that the drugs here are much less efficient. It's easier to treat steatohepatitis than to show fibrosis resolution. So that's a pretty, I would say, good news, maybe not for patients, but at least for the one who believe in surgery, is that the drugs that are claimed to be fantastic for weight loss are a little bit less efficient for MASLD treatment. It's a tougher disease to treat with drugs, especially long-term, and we know that the weight loss is easy to calculate in 1 year, but a lot of recurrence. And if there is weight loss recurrence, there will be liver disease recurrence too. So just to give you an overview of the common literature on the field. So this review will be hopefully published in a few months with many other aspects. So okay, now let's say we know each other. We decided to go a little bit together to join them. So let's do that for real. Let's get engaged. So with surgery for MASH. This is another story, to operate someone because of the MASH. So here we have recent data that are important to know. The first one, of course, is the beautiful randomized trial by our Italian colleague, Gertrude Mingron, and her colleague Verastro, published 3 years ago now, that showed, face-to-face, compared the outcome of fibrotic MASH, so resolution of MASH, resolution of fibrosis on the right, versus lifestyle and drug treatment, what was available then, so not the modern drugs, versus surgery, with 2 operations, doing similarly, as you can see, gastric bypass and sleeve gastrectomy, 3 arms. And you can see that nearly exactly same numbers as us. This is the intent to treat, so those who did not do the biopsy are failure, but if you do the per protocol, where you only count the one with biopsies, exactly the same numbers, 75% of NASH remission. So again, this is a clear-cut demonstration that our longitudinal prospective, not randomized study, was telling the truth, meaning that if you operate patients, you will see 80% nearly NASH resolution MASH resolution at 1 year. And this is, of course, not at all the case with the current medications at that time, but it's not, as you see, so before, the numbers remain very lower for the most recent drugs. So, of course, there is other efforts ongoing. So we are doing one in France, a multi-center trial, which is coordinated in Lille, but we focused on the very advanced patients with F3, F4, those where really the drugs are not very efficient. So this is tough patients, I will come back to that. So this is our Lille NASH Search multi-center trial, but there is also another one in Pittsburgh ongoing with 60 patients target that is still running, and we'll see that in the coming years. So we are expecting to have this randomized trial confirmed by several others with different aspects or different type of patients in the coming years. But there is also other, randomized trial is something, but you know the time it takes, you know the limits, there is always limits to everything, even randomized trial have some limitations. And so it's also important to see the other available evidence. An important one is the evidence from the big cohort of health electronic records, and there is one team in Cleveland, led by Ali Aminian in the USA, which is really doing a fantastic work to follow a big cohort of patients in the real world. And what they found, looking in the Cleveland system, Cleveland clinic system with thousands of patients, they were able to show that those with MASH and mild cirrhosis at histology, with histology-proven diagnosis, they could compare the patients who underwent surgery and those who did not. And they very carefully matched the patients to not, of course, have the bias of only keeping the best patients because of operation. So perfectly matched, as much as you can in this retrospective analysis, but nearly like a randomized trial. And what they showed is that, first of all, look at the red curve. The red curve is the natural history of these patients with severe MASH. This is a disease. It is not like simple obesity. Look at the numbers. Major adverse liver event, that means liver transplantation, liver cirrhosis, hepatocarcinoma. This is things. After 10 years, 1 out of 10 patients will have one of these. Cardiovascular disease, MACE, so severe event, cardiovascular events, 15%. So these patients are really the severe extreme group of patients we are taking care of. But look also the effect of bariatric surgery. For both of these clinical outcomes, of course, you need to have time. You need to have at least 10 years to see these differences coming. But both for the liver on the left, which makes sense, but also for the cardiovascular disease, you can see a dramatic decrease, 1/3 or 1/10 of the events in the bariatric surgery group. So again, of course, not randomized, of course, not prospective, but a very big piece of evidence published in the JAMA a few years ago. And we recently added another piece in the puzzle by looking of what happens if you have the disease, if you are operated, and you don't have the surrogate marker, which is histology. Because all these diseases are not histological disease, they are clinical disease. And all these treatment, exactly like A1C for diabetes decades ago, you cannot claim efficacy because you are correcting a surrogate early endpoint. A1C for diabetes was lower with insulin, but patients were dying more of cardiovascular disease 10 years later. And that is a change of paradigm of 20 years ago. For the liver, it is the same. Every drug which is approved today, it is approved on the sake of liver histology at 1 year. We'll have to come back with clinical data to see that it's translating into clinical outcome. So with surgery, we were able to do that because we had the patients before, we had biopsy at 1 year, and we had follow-up because now the cohort has aged, and we have more than 20 years of follow-up with exhaustive mortality accessible. So here you have the mortality of the patients of the cohort, depending on there were no MASH at starting point, at baseline, in blue. And the other ones are the ones with MASH at baseline, but in red, those who were still with MASH, the 15% with MASH at 1 year, and in green, those without MASH at 1 year. So those who had remission. And you can see that those, besides adjustment to the initial characteristic, to the initial fibrosis, you have the adjusting analysis on the left. You can see that if you have histological remission at 1 year, this translates in improvement in mortality or survival 15 years later. So that's very good. Another very good news for the field. First, you can have remission of the histology, but then if you have that, it is translating into better survival 15 years later. So again, this is not shown with drugs. May take 10 to 15 years, but very good news for the field. This paper is also very well cited because it's for hepatologists important. So that was another piece. But the thing is that at the end of the day, last year, the European and American Association of the Liver Study, so the big association, as our IFSO, but they're even bigger field, has proposed guidelines for the MASLD management. And this field is moving because of the drugs who are just appearing now. They've been waiting decades to have drugs. And for now, there is already 2, maybe very soon 3, drugs that have been approved, at least in the United States and in Europe. So this is the guideline, the final drawing. You can find it in the paper. But of course, what is interesting is that bariatric intervention is on the map. So not so many medical societies have put bariatric surgery on their map. So this is important. There is no superiority claimed, but it's on the map. The other thing is that it's on the map where obviously it is on the map, because what they say is that you can operate patients with MASH, or you should, or you could, if there is an indication because of obesity. So at the end of the day, they don't create any more patients. It's not like the metabolic surgery where you have type 2 diabetes with less than 35 BMI patients. Here, they just say that it's not because you have MASH that you cannot be operated. But hepatologists put this operation on the map. And don't forget that the drugs are very emerging, poorly efficient. So this is important because that gives us, all of us, surgeons, an opportunity to propose this treatment for these patients, even though you should keep the 35 BMI limit if it's the case in your country as it is in France. But this will change, obviously. Okay, but now I would like to go to the road that we are going to go. For better, for worse, meaning that we are together, we decided to go, but the road is not always easy. First of all, I would like to share with you papers that have not been published yet. Many of those will not be published for the rest of the talk, is that when we looked in this cohort, the individual parameter and their relation with the surgical risk. And here what we thought is that the outcome was perfect textbook outcome. The patient who goes in, is operated, and goes out in a few days without no complications. Anyone with anything, of course, it can be death, it was not death, but it can be anything, reoperation, but even less, is a non-textbook outcome. And if you go there, you can see that NAFL, steatosis per se, is not an independent risk factor. Fibrosis, will come back on that, on the bottom line, is a known fibrosis, is a known risk factor, especially cirrhosis. But what we found is MASH, so inflammation itself, without fibrosis, just MASH, independently of diabetes, because of course they travel very much together. So MASH, liver inflammation, is a very high risk factor for complications in liver surgery, in metabolic surgery. Meaning that it can be infection, it can be leakage, it can be anything, but it's just that if you put someone on the table with a MASH, be careful. These patients are not the Mr. Everybody. They are more difficult, they are more at risk. You have to be careful. So this is the next story. So I'm from Basque Country, so I like to surf. So I used to surf a lot. I surf when I can these days. But so this is what we are. So it's a risky thing, but it's a beautiful thing. Let's go there. But you have to be very careful here, of course. This is Teaupo in Tahiti, for those who know. This is a part of France very far away. But anyway, this is, of course, not me on the board, but I was taking the picture. That's for sure. The thing is that this is already quite scary, but this is what you don't want to go. And maybe you have seen this awful chart before, but this is what is going to happen sometimes. It's not only to have risk to fall, but also to die from surgery. And that's something that we don't want. Never, never, never. All of us, of course, we are very keen on that. So be careful, because this is a story. So cirrhosis in MASLD is something. Of course, not all patients have cirrhosis. Cirrhosis means fibrosis 4. But you can see that it goes with time, and from MASH, patients with evolve with severe fibrosis, and to cirrhosis. When you have F3, it's 20% every year that will go to F4. So then you have, of course, in this patient, natural history, decompensated cirrhosis, and of course, at the end of the day, liver transplantation or death. So this is the story, the natural history of cirrhosis in these patients. But in our patient, this is a liver that you may have seen, a long time ago, Dr. Brolin in the States have published this study that says that 40% of surgeons and 1 out of 1,000 patients have been there. So I was operated for bariatric surgery, and I discovered that during surgery. So discover unknown cirrhosis, quite obvious clinically. So here you can see a biopsy, percutaneous, but this is something that we can discuss, but it's really a worrisome situation. I will explain you why. So first of all, just would like to remind you that cirrhosis is known in surgery as a bad guy. Cirrhosis per se, quantified with the MELD score, the MELD score has been quantified by correlating the MELD score, the score, which is a biological score, with mortality. So it's really a very important score for the pathology. This is the indication for liver transplantation, 10 to 15. So what we know is someone with mild cirrhosis, MELD score above 8, if you go for any general surgery, such as a cholecystectomy or anything like that, 5% death rate. This is something we don't want to hear about. Of course, even in our patients, we are now used in our practice to have 1 out of 1,000. This is the number for all France. 35,000 operations a year, 1 out of 1,000 death, exhaustive number. So this is the type of things we are used to, and hopefully for the patients. So we don't want to hear about several % of death rate. This is not possible. I'm not taking my kid in the bus where there is 2% of chance to not arriving at the end of the day. I don't go there. This is crazy. Okay, so we have to be very careful. When you have a cholecystectomy for emergency case, there is little choice. But we put our patients on the table ourselves. So we have to be very careful here. So first of all, that was the bad news. The better news is that our colleagues in America have checked. It is a recent paper, where they checked the post-op mortality in 100 cases of metabolic surgery in known cirrhosis, in proven cirrhosis. From the MELD score, they showed that the predicted mortality should have been, if you take 3 months, but if you take 3 months, 1 month is 8%. So something which is, I told you, so with the MELD at that stage, you have expected these type of things, but in reality, the number observed were much lower. Good news. Nobody knows why, because maybe good centers, we'll come back to that, or other aspects, but the picture was a little bit less. But still, in patients with cirrhosis, non-selected cirrhosis, I will come back to the detail, the observed mortality 1 year later, because you don't die always the first week or the first month, so you have to be a bit longer to check numbers, 3%. So this is serious. But this is not like the crazy 25 or 27% predicted from just the MELD score. So that's a better news. So when we now look with several papers, mostly in the States, where they have been very early confronted to this aspect, the first thing is experience matters. So what they showed in this national-wide base is that if you compare the patients operated in centers with low volume activity and those with high volume activity, you see the difference is quite striking. So in the high volume, it's tough, 1.4% mortality. Cirrhotic patients, again, remember this is exactly the numbers I told you before, 1.4, so 10 to 15 times more than in normal patients. But look at in the low volume centers, 8% mortality in hospital. This is impossible. So that tells you, sure, that these patients are tough, and if you want to take care of these patients, you have to be tough yourself. You have to be experienced, to have been surrounding with a good team, intensive care, hepatologists. This is tough. You want to fix something which is difficult. You have to be careful. First thing, experience matters. Don't go there if you don't feel at ease with these patients. Second thing, very important, is the cirrhosis decompensation matters. There is a very big deal between fibrosis 4, histologically, with no sign of decompensation, and those with clinical decompensation. I will come back to the details. So again, look at the numbers. If you look everyone, again, you have this 1.8%, but if you compare both, if the decompensated cirrhosis is studied, 20% mortality. Crazy. 1 out of 5 patients for, let's say, scheduled surgery dying from the surgery. Crazy. We don't want to go there. So obviously, you need to screen for advanced liver disease your patients. First, you want to diagnose those with advanced liver but compensated disease, but you want also to screen for the very bad ones. Important one, for screening the patients, we have tools which are simple, which are non-invasive tests, biological tests, a blood test, and several scores. There is tons of scores that have been published in the literature, but the most important one are the two ones, LFS, FIB4. And you'll see that there is tricks with our patients. The first tricks, which was shown in Scandinavia a few years ago, is that this is just by numbers. NFS, the most useful test in the hepatology normal world, is also counting BMI. So on the upper right, you can see that the performance is going down when BMI is going up, because it's confused by BMI. So in our severely obese patient, NFS is just nonsense. It doesn't exist. It's not useful. So forget NFS for our patients. FIB4, on the other hand, which has no BMI in the score, is interesting, but look at he has age, and I will come back to that a bit later. So FIB4, which is the most common one in the practice of hepatology, is interesting, but be careful, our patients are pretty special. So this is a story we've done recently with all these tests in our cohort, and what you can see here is that indeed FIB4 is a good one, but the best score to use, it is not yet totally on the prime time, but it's a Spanish score. It's a beautiful Spanish Lancet paper that has been published 3 years ago, retrospective analysis, fantastic work of artificial intelligence with a liver risk score. It is not very well known yet worldwide, but it's 10 simple biological clinical aspects. It's online, and you can have a score. And this is the best predicting score for diagnosing severe fibrosis, best available. FIB4 is okay at baseline, but look at when we looked and compared with biopsy at 1 year and 5 years after surgery, interestingly, FIB4 is useless for following the story because patients are aging. And so the FIB4 is confused. Patients are aging and the fibrosis is regressing. So the FIB4 is lost. So in the down there on the right, you have the best, again, the liver risk score. So just remind this number, it will increase. Worldwide is increasing. This is and it is Spanish, by the way, so you should be happy of that. And it's probably more used in Spain than in other countries, but it's very, very interesting tools. It has more component, and it takes into account also metabolic aspects and not only liver aspects. So, but that's another story, just to tell you that it's not so easy to test for severe fibrosis in our patients with severe obesity. It is not easy neither to follow the fibrosis regression with this test because patients are aging, there is a lot of confusion, and these tests were not done for that. Okay, so at the end of the day, what we want to do as surgeons, we want to rule out the decompensated cirrhosis. So of course you have this test, you have screening for the patients with disease signals, but then you have to remain simple. Clinical symptoms, any clinical symptoms associated with cirrhosis, ascites, jaundice, bleeding, digestive bleeding, encephalopathy is a no way. This is clinical symptoms, okay. Biology, the MASLD is here the best one to follow the important patients. Again, very simple scoring. If you have any of this suspicion of clinically decompensated cirrhosis, you have to go to measure portal hypertension. And if there is portal hypertension, that means it's a decompensated cirrhosis. You can measure it with portal measurement, portal pressure measurement, above 10 millimeters of mercury. You can image, you can see the varices. If you have varices at the upper GI, forget it, it's decompensated. No way. Okay, so what do we do? For just one slide of that, because this is quite a little niche. For this patient in decompensation of cirrhosis, the treatment is liver transplantation. Okay, but what they learned, our colleague, like for the virus, if you don't treat the virus and you transplant someone, you will have recurrence. Same thing for us. If you transplant someone with a metabolic syndrome, obesity, for MASH cirrhosis, you will have recurrence on the liver. So what they are now proposing, some of them, is to combine transplantation and metabolic surgery. So this is a tricky, of course, a narrow and tricky field. So the most advanced are the American colleagues, and they published recently a beautiful retrospective multi-center trial. We're not talking about thousands of patients, but 150. And they just compared, not randomized, they compared the strategy that is promoted in the States, because patients are traveling a lot for their liver transplant, to have both operations at the same time, same sequence. So liver transplantation, and when it's done, sleeve gastrectomy to the same operation. Okay, what are the message of this paper? So this is quite brave, but it is feasible, you know. Maybe you know that if you have also postponed the metabolic surgery after transplantation, as we do normally in Lille, you would be surprised that it's not difficult to operate someone with a liver transplant because there is no adherence because of the immunosuppression, and the anatomy is quite normal. So doing a gastric bypass after a liver transplant is like doing a gastric bypass to anyone. I understand that at the time of liver transplant, gastric bypass may seem a little bit too much with all the anastomosis, arterial, venal. Okay, so this is the proposal. What they found is that, of course, adding sleeve gastrectomy to the liver transplantation, more weight loss, more reduction of diabetes, and more regression or less steatosis recurrence on the liver transplant. This was done by imaging later. But on the other hand, small series, they were not able to show any clinical difference in mortality comparing liver transplant alone or liver transplant and sleeve gastrectomy. They lose weight, they lose diabetes, there is less steatosis on the liver graft, but they didn't show improvement in survival or graft loss or retransplantation. So just message. It is just ongoing work, we don't know yet. In our hand, what we prefer is to do the liver transplant and to do the metabolic surgery when everything is going good a little bit later. But of course, this is a matter of schools, and of course in France, patients are not traveling so much. It's not a big deal to have them back after a few months. So no conclusions here, but just a recent paper which is very interesting. Okay, another very interesting paper is now we are leaving the decompensated cirrhosis, which is a difficult field, and we go back to our field, which is advanced MASLD, compensated cirrhosis. Another very important recent paper by Ali Aminian from the Cleveland cohort. Now he looked at patients with cirrhosis, compensated cirrhosis, that were operated to little bit before it was MASH. Here it's patients with cirrhosis, documented F4 at histology. And he looked what happened comparing these patients operated with match control as much as we can, so the similar patients who, in this real-world story, were not proposed to be operated with metabolic surgery. And again, you see a very important difference, a very big advantage for metabolic surgery in these patients, either on the major liver outcomes, remaining cirrhosis, hepatocarcinoma, or liver transplantation, and on the other one, this is the liver outcome, sorry, so cirrhosis on one hand and the other on the other hand. So again, a very big difference, protecting patients from severe clinical outcomes. So in favor of surgery in compensated cirrhosis. Now we go to the end of the talk, but just to go in the future world, which is now if we want to go there and to operate these patients, which procedure? This is the next question for us, because we are surgeons and we want to know what to do. So this is difficult. It's a new field. There is not so much literature, but this is what exists in the States. That's from the States. So observation of the tendency of practice in the States in patients with compensated cirrhosis. And you can see in red the gastric bypass, in blue the sleeve gastrectomy, for all these reasons. And you can list less risk postoperative. Maybe also the idea that you can still do some endoscopy, so to look at the esophageal varices. So everyone, you can still do endoscopy, invasive endoscopy, interventional endoscopy. So hepatologists are more with that. So obviously there is a tendency toward sleeve gastrectomy. By the way, you know that this modern tendency in modern countries such as Scandinavia, gastric bypass is going up. More gastric bypass than sleeve in Scandinavia in the recent years. So this is the tendency. But I would like to finish with very new data. Am I okay with the time?
Yes.
Okay. Okay, so the idea is that we wanted to go there, to add something to the idea of what operation should we do. I showed you the observation in the States for compensated cirrhosis, but what for the non-cirrhotic patients, the patients we see? Should we propose sleeve or gastrectomy? I don't know if you're familiar with this open evidence tool, but it's available. You can use this to explore the surgery, to do review on real time. If you ask to open evidence, what is the operation of choice, he will answer as the randomized trial after 1 year, similar results with gastric bypass and sleeve. So he will say there is no improvement in one or the other, maybe a small advantage for lesser risk in sleeve gastrectomy. So we wanted to address this question. I will finish with this unpublished result for the next 5 minutes. So what we did in our cohort, we compared the patients who were operated for at-risk MASLD. So the MASLD with MASH, proven MASH, or fibrosis 2, so the advanced disease. So we had this number, 300 patients, in this case, in our cohort, that we followed. You can see here the numbers. It was not decided either by the patients, so meaning that they are similar. The group are very similar. You can see that. You can see the classical things for us. BMI 48 was the same in both groups. 2/3 of diabetes. Again, association is very tight with, and fibrosis plus than 2. So you can see very similar group. And to even more compare the group, we did this propensity weighting, which is a statistical method to even more qualify the two groups. And you can see at the end, the two groups at baseline are exactly similar. What we found is, as expected, especially in patients with severe disease, weight loss is lower with sleeve gastrectomy in blue. This is for 5 years. But you can see that because French doctors do well, A1C is good, because they put more drugs, or there is less remission, but they do quite good, and A1C in the mean was similar in both groups. Same, and that's a surprise for AST. AST, transaminase, is not enough to follow the patients. So this is what we found. But now if we go to the histology, because we have histology for these patients, you can see that, as expected from the weight loss, sleeve gastrectomy has a slightly less remission rate at 1 year for MASH, which is even more obvious at 5 years because there is recurrence of weight. And you can see here that this goes also for the fibrosis. So histologically, it seems to be an advantage. But what we did, here we go to clinical things, because now we know that this is surrogate endpoint. We want to have the story. We want to have survival. And this is what we found. This was surprising for us, and I will tell you that we controlled that independently. What we found is that in these patients, and the group were very well matched, gastric bypass does much better to save life. Because, of course, we are now talking about 15 to 20 years. Of course, there is problems in the beginning. There is a little bit of complications. We had 1 death in the gastric bypass group in the first year. But still, at the end of the day, there is a clear advantage in terms of mortality. And maybe you've seen that the same results have been published in Sweden recently for diabetes. Gastric bypass is better to fix the disease and to improve survival when you have enough time. Because it is important result and quite disruptive, because the message is disruptive, we went there in our colleague in Paris. There is another cohort with histology, because you need histology to do that. And we follow up with the French system is the same. So again, 600 patients, different team. So you can see they're a little bit less diabetic in their groups, but at the end of the day, with the waiting process, we had similar groups. And look at that, different team, a little bit less follow-up, but same thing. Half the risk for mortality is decreased by 2 in their cohort as it is with us. So quite strong confirmation with external validation of this data. Okay, all the story has to end. So this is the end of mine. So I would like just to leave you with few bullet points. First one, I am convinced that in this changing world, MASH, especially MASH and advanced MASLD, will become an increase as an indication because the drugs will have difficulties because you need long-term effect here. And there is no benefit for 1 year weight loss in these patients. It's more about 5 or 10 years. Second message, you really have to screen your patients. You have to screen your patient both for finding indications for the severe advanced disease, but also to avoid compensated cirrhosis, to avoid decompensated cirrhosis. You have to be very careful. If you do that carefully, MASH will disappear in 80% of cases. This is quite a result. 8 out of 10 patients will have no disease at 1 year, persisting at 5 years, with mortality advantage. Fibrosis also can regress if you wait enough time, 5 years or more. Don't forget that MASH per se, and of course fibrosis, increases the surgical risk. Don't talk about decompensated cirrhosis. And please remind only one thing, don't operate someone with 20% risk of death. And at the end of the day, I propose that Roux-en-Y GB, so gastric bypass, maybe others, operation that you're familiar with, but so far we don't have data, could be, and we think, is a better option than sleeve if the aim is to fix the disease. And there is a disease to fix. You don't want to have a sleeve after a transplantation. You want to have a gastric bypass to avoid transplantation. You want to fix a severe disease. And that's, in our idea today, even if it's a little bit more risky to start with, the best option to propose to our patients. And with that, I thank you for your attention. And just to explain this picture, so this is the team. You can see Robert and the team in the patient, but this is not the team. This is patients on enrollees of the cohort that every year are invited to a patient research day. So every year we do that. So we have 5 researchers that have to explain to the patients what they did and found with their samples and data. My calculator, my liver biopsy, and it's an amazing day, and the patients love it. And so this is part of the keeping them in the loop. So this was Obesity Day a few weeks ago. And with that, I really thank you for your attention.
Thank you very much, Francois. There is no question for this outstanding lecture. There is no question at all. I think, it's enough information. Thank you. This is one of the reasons we are so honored to having you as an honorary member of our society. Thank you so much, Francois.
Thank you.
Bueno, y ahora a continuación ya dejo a la presidenta aquí que guíe el resto de la sesión, que tiene mucho trabajo que hacer, de premios, de dar cosas, y así que nosotros nos vamos.
No hace falta que os vayáis, por favor.
Sí, vosotros sois los que...
Bueno, vamos a entregar, en primer lugar, los premios de las becas SECO correspondientes al año 2026 a los proyectos de investigación. Tenemos 3 proyectos que se han concedido. El primero corresponde a los proyectos de investigación de carácter experimental y en base a lo emitido por el comité científico, el premio se da al investigador principal del proyecto Microbiota intestinal y evolución metabólica a largo plazo tras cirugía bariátrica, estudio longitudinal en una cohorte de pacientes con obesidad severa, al doctor Andrés Balaguer Román.
Enhorabuena, Andrés.
Mejor porque así no tenéis que saltar, me dice. El segundo premio de investigación corresponde a los premios de proyectos de investigación de carácter clínico y el título es Ensayo clínico sobre el efecto del ejercicio físico dirigido tras cirugía bariátrica en la masa muscular y en la densidad ósea, OBFIT. Y los doctores que lo presentan son Isaías Alarcón, Manuel Antonio Pinelo Trancoso, Francisco Almoguera, Ana Senén, Diego Munguía y Javier Bueno. Y el tercer premio a los proyectos de investigación, esta vez de carácter multidisciplinar, se concede a la doctora Carmen Serra Saus por el trabajo, el proyecto Estigma relacionado con el peso en pacientes con obesidad en un programa de cirugía bariátrica, análisis transversal y evolución tras la intervención quirúrgica. No sé si se encuentra en la sala, ¿no? Bueno, pues se lo haremos llegar y la felicitamos. Por otra parte, en una reunión express del comité científico y en ánimo de poder comunicar un poco los beneficiarios de las becas, en cuanto a fase 2, la persona merecedora de la beca es Victoria Antolín, no sé si se encuentra en la sala. Fase 4 sería Estíbaliz Álvarez y Leónidas Omar, ¿sí? Y en cuanto a la IFSO de Toronto, se han concedido finalmente 7 becas porque ha habido un ajuste económico que se ha podido realizar y las becas se conceden a Ruth López, Margarita Vives, Gabriel Martínez, Álvaro Martínez, Andrés Balaguer, María Recarte y Sara Picazo. Y finalmente vamos a un acto también muy bonito, que es el pase del testigo, un testigo que pesa mucho y que lo va a entregar el presidente del Congreso actual al presidente del Congreso futuro el año que viene en Almería, el doctor Manu Ferrer.
Ahí abajo, ¿no?